first of all, this bill, it's a bipartisan bill that you introduced last summer. And in it talks about these PBMs. I must admit, when I first saw the bill last summer, I'd never heard of a PBM. What is that? Can you explain that?
That's exactly the way they like it. They like being in the middle of a complicated supply chain, and they are shielded from public scrutiny and congressional scrutiny. They can be rent seekers, and they are taking about $300 billion from the U.S. healthcare system every year. And what the pharmacy benefit managers do, there's 3 of them owned by the big health insurance lobbies, is they process claims and reimbursement for the pharmaceuticals, that you buy at pharmacies throughout the country. And in that role, a lot of money crosses their transom, and they got greedy. It's time to rein them in. We can save taxpayers $5 billion and lower co-pays and premiums with bipartisan legislation that we had on the docket ready to pass last Congress.
How are they getting paid? Are they taking a piece of the action? I mean, why are they making so much money?
They are very inventive in how they do this. One is called spread pricing, where they basically bill the insurance company more than they actually pay the pharmacist for the drug. And they do that for taxpayer-funded health insurance as well, Medicaid and Medicare. One is rebates, which is a polite word, frankly, for kickbacks. They actually have safe harbor from a law called the anti-kickback statute. Can you imagine that? They came to Congress in the 1990s, and they got safe harbor from a bill that was designed to prevent kickbacks. So what have they done since then? They've gotten kickbacks, of course. The higher the list prices go for drugs, the more of the margin that they can take on that higher list price.
All right, so they get money, and is this? I mean, what's the benefit to the pharmaceutical industry?
There's no benefit to the pharmaceutical industry.
Why did they? I mean, I still don't get why we have them.
So the original reason for them, and we do actually need somebody to do this role, is to design and enforce a formulary. And what that really means is it says to the big pharmaceutical companies, if you have a brand drug, which is expensive, and there's a generic drug, which is cheap, but does the same thing therapeutically, the patient needs to try the generic drug first. And that lowers prescription drug costs over time because it creates competition and choice. That's a good thing. We actually need someone to do that. They should be charging a flat rate, though, for that service, like 1 or 2% probably. Instead, they have squirreled themselves into this supply chain and have been extracting rents not based on a flat rate, but rather the higher the drug price goes, the more they get paid. So what do you think happens to drug prices? It goes up.
All right.